Hey friends, I'm back again, and now, before I tell you about normal labor and about the mechanism of normal labor, first I want all of you to understand various terminologies related to labor. And you know the drill. What I'm going to do is, first I'm going to show you, I'm going to tell you the concepts related to the various terminologies, the definitions of the various terminologies. First, you are going to understand what I'm telling you, and then you are going to copy what is written on the slides. The first terminology we are going to understand is lie. Now, what is lie? See, lie is the relationship between the long axis of the mother and the long axis of the fetus. Right? So what is lie? In a very simple manner, lie means the relationship between the long axis of the mother. Now, what is the long axis of the mother? The long axis of the mother is the maternal spine, right? Or if you are seeing in terms of uterus, then the long axis of the mother is the axis of a centralized uterus. So once you have centralized the uterus, because you know that in pregnancy the uterus becomes dextro-rotated. So first centralize the uterus with your own hands and then see what is the relationship between the long axis of the mother or the long axis of the uterus, a centralized uterus, and long axis of the fetus, right? Now, if suppose the long axis of the mother and the long axis of the fetus, they are coinciding with each other. That is what is called as longitudinal lie, and that's the most common lie, right? Second thing could be that the long axis of the mother and the long axis of the fetus, they are at an angle to each other. So if long axis of the mother and long axis of the fetus, they are making an angle to each other, that is what is oblique lie, right? And the third situation could be that the long axis of the mother and long axis of the fetus or the baby, they are perpendicular to each other. Now, if long axis of the mother and long axis of the fetus, they are perpendicular to each other, that is what is called as transverse lie. And in case of transverse lie, vaginal delivery is not possible. Always you have to go for a cesarean section, whether the baby is alive or whether the baby is dead. Always the management for transverse lie is cesarean section. Please remember that destructive procedures for transverse lie in case of dead baby are no longer used. Right? So even if your question is saying that there is a dead baby with transverse lie, your management will be cesarean section. Is that clear to all of you? And I told you the most common lie is longitudinal lie. Now sometimes what happens is that the lie of the baby, okay, so before I shift to that, you can see here on the PPT in the images, this is what is longitudinal lie. So this is the long axis of the mother in pink color, right? And I am making in blue color the long axis of the baby. So when long axis of the mother and long axis of the baby, they are coinciding, that is what is longitudinal lie. And if long axis of the mother and long axis of the baby are at 90 degrees, that is what is transverse lie. And if long axis of the mother and long axis of the baby, they are making an angle which is less than 90 degrees, obviously, that is what is oblique lie. Right? Now, in transverse lie and in oblique lie, in both these conditions, you have to go for a cesarean section. Right? Now, there is something which is called as unstable lie. What is unstable lie? Unstable lie is a condition when the lie of the baby is not fixed even by 37 weeks of pregnancy, right? So if lie is not fixed by 37 weeks of pregnancy, that is what is called as unstable lie. And if someone asks you what is the most common cause of unstable lie, the most common cause is idiopathic. But apart from idiopathic, it could be because of polyhydramnios. In polyhydramnios, there is excessive amniotic fluid. So sometimes the baby becomes longitudinal, sometimes it becomes oblique, sometimes it becomes transverse lie. Then it can also be due to placenta previa, or it can be due to abnormal shape of the pelvis. What I want you to remember is what are not the causes of unstable lie. Oligohydramnios does not lead to unstable lie. It's polyhydramnios which leads to unstable lie. And uterine malformations, they do not lead to unstable lie. Uterine malformations can lead to malpresentations, but they do not lead to unstable lie. Right? And if you have unstable lie, again the management is cesarean section. Right? So this is what I wanted to tell you about lie. Now comes the next terminology, and the next terminology is the presentation. Now, presentation is that part of the fetus which occupies the lower pole of the uterus, right? So that part of the fetus which occupies the lower pole or the lower part of the uterus, that is what is presentation. Now, in case of longitudinal lie, either the head of the baby can be facing down. Now, when head of the baby faces down, that is what is called as cephalic presentation, right? Or it could be that the legs or the buttocks of the baby are facing down. Now, when the legs or the buttocks of the baby are facing down, that is what is called as breech presentation. The most common presentation is cephalic presentation, right? And this is the only normal presentation, right? So when we say the normal presentation means we are talking about cephalic presentation. Now, my next question to you is, why is it that cephalic presentation is the most common presentation? Cephalic presentation is the most common presentation because of two reasons. Now, if you look at the shape of the uterus is broad from above and it is narrow from below, right? And if you look at a baby, right, in a baby, I'm not talking about this baby, in a normal baby here, this is the measurements are not accurate and they're not even proportional. Now, in a normal baby, the buttocks are broad and head is small, right? So very gracefully head says to the buttocks that I need less space, so I will go down, you can go up. And that is why you have cephalic presentation, number one reason. Number two, because of gravity, head comes down, head being heavier will come down, right? That is why cephalic presentation is the most common presentation and it is the only normal presentation. If there is any other presentation apart from cephalic presentation, that is what is called as malpresentation. Right? Now, because the most common lie is longitudinal and because cephalic is the most common or the normal presentation, so if I ask you what is the most common malpresentation, most common malpresentation would be breech. So normal presentation is cephalic, most common malpresentation is breech. Is that clear to all of you? Right. Now, what happens in case, so over here, before I go further, you have images where you can see you have a cephalic presentation where the head of the baby is facing down, the lie is longitudinal, and here also the lie is longitudinal, but the buttocks are facing down, so this is breech presentation, right? Now, what happens in case of transverse lie? In case of transverse lie, it is the shoulder of the baby which is coming down, right? So, in case of transverse lie, the presentation is shoulder presentation. So, whether I say transverse lie or whether I say shoulder presentation, that's one and the same thing. So now if I ask you, what is the management of shoulder presentation? You will say, ma'am, management of shoulder presentation is cesarean section, whether the baby is alive or whether the baby is dead. So whenever a transverse lie patient comes to you in labor, you have only one option, and that is cesarean section. Why I have added this word in labor is because when I will talk to you about transverse lie, I will also tell you that if the patient of transverse lie comes to you in the antenatal period, you have one option, that is you can per-abdominally rotate the fetus. Right, so I'm not talking about that just now. So I'm just now saying, if a transverse lie patient comes to you or a shoulder presentation patient comes to you during labor, I have just one option, and that is I have to go for a cesarean section. Right? Now, about transverse lie, one other very important point you have to remember is, and that is, in transverse lie, there are maximum chances of cord prolapse. Right? So let us understand that why, first we will understand that why in cephalic and breech there are not maximum chances. Once we understand that, automatically we will understand that why in transverse there are maximum chances. Right? So look over here. This over here is cephalic presentation, right? And suppose my hand is the internal os. Now all of us know that at the time of labor, right, at the end of first stage of labor, the cervix is fully dilated, right? And a fully dilated cervix is 10 centimeters, right? Now we also know that membranes are ruptured normally. Normally membranes rupture at the end of the first stage of labor. So at the end of first stage of labor, when the cervix will be fully dilated, that is 10 centimeters dilated, membranes will rupture. Now, in case of cephalic presentation, when the membranes will rupture, head of the baby will come down and it will close this 10 centimeters of the cervix, right? And it will not allow the cord of the baby to come out. That is why in cephalic presentation, the chances of cord prolapse are less, right? Similarly, if there is breech presentation. Now, in case of breech presentation, the buttocks of the baby are facing down, right? Again, the same thing would happen, that when the cervix will be fully dilated, that is when the cervix is 10 centimeters dilated, what is going to happen? Membranes are going to rupture, and when membranes will rupture, the buttocks of the baby will come down and they will close the mouth of the cervix and they will not allow the cord to prolapse, right? That is why in breech also the chances of cord prolapse are less. Yes, definitely in breech, depending upon the variety of breech, I will tell you more things. But as of now, we are talking about comparing cephalic and breech to transverse lie, right? Now, in case of transverse lie, suppose this patient, right, she is belonging to some rural area where these people, they do not believe in getting a cesarean section done, right? And, Dai sees this patient and she says that I am going to go for a vaginal delivery. I will attempt vaginal delivery. Now, when this patient will be, when she will be undergoing vaginal delivery and when the cervix will be fully dilated, right? 10 centimeters dilated. Now, is there any part which can come down and close the cervix? No. There is no part which can come and close the cervix. That means the cord has to come out, right? And that is why we say maximum chances of cord prolapse are in transverse lie. Is this clear to all of you? Right? And that is why if transverse lie is there, you have to do a cesarean section. There isn't any other option, right? Not only this, suppose this Dai is, trying to deliver this patient now, and she's trying to pull the baby out. Now, when this Dai will try to pull the baby out, the only part which she will be able to hold will be the hand. So what she will do is she will try to bring the hand of the baby out. The hand of the baby will come out, but the rest of the body will not come out. And if hand of the baby is seen hanging out from vagina, that is what is called as hand prolapse. So in case of transverse slide, there can be cord prolapse, and if you are trying to meddle with the baby, right, then there can be hand prolapse also, right? Is that clear to all of you? So in case of transverse slide or in case of shoulder presentation, whether the baby is alive or whether the baby is dead, you should go for a cesarean section, right? Now, the last thing is about presentation is, suppose if it is not just one part which is occupying the lower pole, suppose two parts of the baby are occupying the lower pole of the uterus, right? So if any two parts of the baby are occupying the lower pole of the uterus, then that is what is called as compound presentation, right? Now, after presentation, the next term is presenting part. Now, what is presenting part? Presenting part is that part of the presentation which lies directly over the internal os, right? So, presenting part is that part of the presentation which lies directly over the internal os, and it is first felt when you do a per-vaginal examination, right? So, over here, normally, I told you that the baby is fully flexed, right? And the relationship between different parts of the baby, that is what is called as attitude. So normally we say the attitude of the baby is that of flexion. All the parts of the baby would be flexed. Head of the baby would be flexed, hands of the baby would be flexed, legs of the baby would be flexed, right? Now, when the head of the baby is fully flexed, now, when I will do a per-vaginal examination, my fingers will touch the vertex, right? And that is something which we've already done. So, in case of fully flexed head, in case of partially flexed head, and in case of deflexed head, what will be the presenting part? Presenting part will be vertex, right? In case of partially extended head, in case of partially extended head, when I will do a per-vaginal examination, my finger will touch the brow. That means brow is lying directly over the internal os. So, in partially extended head, the presenting part is brow, right? Whereas, in case of fully extended head, in case the head is fully extended, now when I will do a per-vaginal examination, my fingers are going to touch the face. That means face is lying directly over the internal os. So, in a fully extended head, the presenting part is face, right? So, if I ask you what is the most common presenting part? Most common presenting part is vertex. Why? Because normally the parts of the fetus are flexed, right? Is that clear to all of you? Is any confusion still here? Okay. Now, let me introduce one more term to you, and that is attitude of the fetus. So, just now I told you what is attitude of the fetus. Attitude of the fetus is relationship between different parts of the fetus. And the most common attitude is that of flexion, right? So this means presenting part always depends on the attitude of the baby, rather than saying whether the head is fully flexed, fully extended, partially extended, saying so much. We can simply say that presenting part depends on the attitude of the baby, right? And a normal attitude is that of flexion. Abnormal is that of extension. In other words, brow and face presentation. Brow and face are examples of abnormal attitude of the baby. Because brow I am going to get when the head of the baby is partially extended. Whereas normally the head should remain flexed. Now here it is partially extended. That means there is abnormality of the attitude. Similarly, face I am going to get when the head of the baby is fully extended. In other words, again, face is an abnormality of the attitude. So many times they give you this question that face presentation is due to abnormal. Option A, presentation. Option B, lie. Option C, attitudes. What are you going to mark? Face presentation is due to abnormal attitude of the baby, right? And as far as bro is concerned, I told you, in case of bro, you always and always have to go for cesarean section. Why? Because in bro, the engaging diameter is mento-vertical diameter, which is 14 centimeters. In case of vertex, what was the engaging diameter? It was SOB, S-O-B. I told you that, suboccipito-brachmatic, that was 9.5 centimeters. In case of deflexed head, although it is vertex, but what is the engaging diameter? Engaging diameter is occipitofrontal or suboccipitofrontal. And in case of face, what is the engaging diameter? In case of face, it is submento-brachmatic or submento-vertical. That all we have done when we did fetal skull, right? Now comes the next point, and that is denominator. Now first, before we go to denominator, first understand here. If I place the baby like this in the mother, and I ask you to define the lie, you are going to say it is longitudinal lie. I tell you what is the presentation, you will say, ma'am, presentation is cephalic. I tell you what is the presenting part, you will say head is fully flexed, presenting part is vertex, right? Now, if I move the baby like this, then also it remains the same. You will say, ma'am, lie is longitudinal, presentation is cephalic, presenting part is vertex. If I move the baby like this, then also it's the same, lie longitudinal, presentation cephalic, presenting part vertex. If I move the baby like this, then also it is the same. So that means, till now, although I have told you so many things, still I am unable to tell you how exactly the baby is lying in the mother's uterus. So if you are assisting me in delivery and I want to tell you that how is the baby lying in the uterus, by telling you only this much, that lie is equal to longitudinal, presentation is cephalic, presenting part is vertex, you will not get a clear picture of exactly how the baby is inside the uterus, right? For that, we will need something more, right? And in order to get that something more, one more term which you have to understand is denominator. Now, what is the denominator? Denominator is a bony point of reference which is present on the presenting part, and it comes in relationship to the maternal pelvis. So it is this bony point of reference which is going to come in relationship to the mother's pelvis, right? So I'm again telling you what is a denominator. Denominator is the bony point of reference on the presenting part which comes in relationship, to the maternal pelvis, right? So in case of vertex presentation, the bony point of reference becomes the occiput, right? In case of bro, the bony point of reference becomes the frontal eminence or the frontal bone, right? The frontal eminence or the frontal bones. In case of face, the bony point of reference is the chin or the mentum, right? And in case of breech, the bony point of reference is the sacrum, right? Now, as I told you that the most common is vertex, so we are going to talk first about vertex only. In other words, the bony point of reference which we are going to talk about is the occiput, right? Now, this over here is the mother's pelvis, right? This is the left side of the pelvis. This is the right side of the pelvis, right? Left hand, mother's right hand. This over here is sacral promontory. That means it is posterior part. And this over here is pubic symphysis. That means it is anterior part, right? Now suppose if the occiput of the baby, so for occiput just look at this red dot. Now if occiput of the baby is like this, if the baby is present like this, right? Now if baby is present like this, then we can see that the occiput is facing anteriorly and it is just behind the pubic symphysis. So if occiput is facing anteriorly and it is just behind the pubic symphysis, we say it is direct occipito-anterior position, right? So now if I tell you, bache, please define the exact position of the baby, you are going to say, ma'am, the lie is longitudinal, presentation is cephalic, presenting part is vertex, and position is direct occipito-anterior position, right? Now suppose if I turn the head of the baby like this, right, like this. Now I tell you, now tell me, now define. Now you will say that, ma'am, again the lie is longitudinal, presentation is cephalic, presenting part is vertex, but now the occiput is facing posteriorly towards the sacral promontory and it is directly, facing towards the sacral promontory. So it is direct occipito-posterior position, right? So if occiput is facing anteriorly, it is direct occipito-anterior position. If occiput is facing towards the sacral promontory, it is direct occipito-posterior position. Till here it is clear to all of you? Okay. Now suppose if the occiput is facing anteriorly, but it is not directly behind the pubic symphysis. It is still anterior, but it is not directly behind the pubic symphysis. Now, because it is anterior, obviously I will say it is occipito-anterior. And because it is facing towards the mother's left side, I will say left occipito-anterior position, right? So, if the baby is like this, occiput is anterior and it is facing towards the mother's left side. So it is left occipito-anterior position. Similarly, if occiput is facing like this, now again the occiput is still anterior, but it is now facing towards mother's right side. So it will be right occipito-anterior position. Right? Here it was left occipito-anterior. This was direct occipito-anterior, directly behind pubic symphysis. This is right occipito-anterior. Right? Same thing we are going to do posteriorly also. So, if the occiput is lying directly in front of the sacral promontory, that is direct occipito-posterior. If the occiput is lying posteriorly, but it is towards mother's left side, then that will be left occipito-posterior. If the occiput is facing posteriorly, but it is towards mother's right side, it is right occipito-posterior position. Clear to all of you? Right? So, till now you have done 6 positions. Left occipito-anterior, direct occipito-anterior, right occipito-anterior. Direct occipito-posterior, left occipito-posterior, right occipito-posterior. Right? Now suppose the occiput is in the midway. It is neither anterior, it is neither posterior. So it is neither near to pubic symphysis, neither it is near to sacral promontory. It is midway between the sacral promontory and pubic symphysis. That is what is called as occipito-transverse position, right? Now over here, it is occipito-transverse and it is facing towards the left side of the mother. So it is left occipito-transverse position, right? And over here, it is occipito-transverse, but it is facing towards mother's right side. So it is right occipito-transverse position. First tell me, have all of you understood what positions are? Now, if you have understood what positions are, can you see the difference between left occipito-transverse, that is LOT, and transverse lie? In transverse lie, the entire baby is transverse, right? Whereas in left occipito-transverse, what do you mean? Left occipito-transverse means lie is longitudinal. Presentation is cephalic, presenting part is vertex. It is only the occiput which is lying in the transverse direction, right? In transverse lie of the baby, vaginal delivery is not possible. Whereas LOT, left occipito-transverse, is the most common position for vaginal delivery. So just now I'm going to tell you which position is the most common. Most common position for vaginal delivery is LOT, left occipito-transverse position. Clear to all of you? Now just quickly I'm going to tell you all these positions again. Again I want all of you to see here. So in front of me is anterior, I am posterior, my left hand is left and this is my right hand, right? Now, if the occiput of the baby is in transverse direction, right? It is neither anterior nor posterior. That is occipito-transverse position. And it is facing towards my left side. So, it is LOT position. LOT is the most common position during vaginal delivery. And then it takes a turn like this. Right? So the second most common becomes, now see, again occiput is anterior now, but it is facing towards the left side. So it is left occipito-anterior position. Now it is direct occipito-anterior position. Right? Now if I turn it like this, it is still anterior but on the right side. Right occipito-anterior position. Now, it is in transverse direction, neither anterior nor posterior, but towards the right side. So, right occipito-transverse position. Then, right occipito-posterior. Then, direct occipito-posterior. And then, left occipito-posterior. Clear to all of you? So these are the positions, and starting from LOT and taking a circle like this, that is the order in which they are, they decrease from common to less common. So most common is LOT, second most common is LOA, and that is where so many of you do mistakes. Most common position is LOT, bachcho. Second most common position is LOA. Is that clear to all of you? Let us draw a diagram which is going to be there with you in your notebooks so that when you have to revise positions, this is the diagram which you are going to look at. So we are going to draw a pelvis. This over here is a pelvis. This is posterior. This is anterior. This is left. This is right. Okay. Now, and like this, right? So this over here is the first position and this is LOT. If occiput is lying here somewhere, then this is the second position, that is LOA, left occipito-anterior position. If occiput is lying here, this is direct occipito-anterior position. If occiput is coming here, this is the fourth position and that is right occipito-anterior position. Then you have the right occipito-transverse position, right occipito-posterior position, direct occipito-posterior position and left occipito-posterior position, which is the 8th position, and that's the rarest position to occur, right? Now, from this image, if I ask you, tell me, amongst occipito-anterior positions, which is more common? So, you will say, ma'am, amongst occipito, and as I told you, this is how it goes, right? So, this will be the most common and this will be the least common, right? So, amongst occipito-anterior positions, which is the most common? Amongst occipito-anterior positions, it is left occipito-anterior position, which is most common. Now, look at this image and tell me, amongst occipito-posterior positions, which is more common? Amongst occipito-posterior positions, we can see here that right occipito-posterior position will be more common than left occipito-posterior position, right? Now, till the time baby is lying in, occiput is either occupying first, second, this is third, fourth, fifth, 6th, 7th, 8th. Mark all these positions from 1 to 8 you have to mark, right? Now, till the time baby is lying in any of these positions. So, if vaginal delivery is happening and the occiput is facing from position number 1 to position number 5, any of these positions, then such a vaginal delivery is called as a normal vaginal delivery. Right? So, if you are doing vaginal delivery and the head of the baby is lying from position number 1 to position number 5 in any of these positions, you will say that I have done a normal vaginal delivery. But suppose you have done a vaginal delivery and the occiput was facing from position number 6 to position number 8. Then you will not say that I have done a normal vaginal delivery. You will say that I have done occipito-posterior delivery. Right? Is that clear to all of you? So, I'm going to make you write all this also. So, look over here. As I told you, from position number 1 to position number 8, everything is marked here, and that is a simplified diagram which you have drawn. Right? Okay. So, now I want all of you to write this. Vaginal delivery is said to be normal vaginal delivery if position of the fetus is from position number 1 to position number 5. From position number 6 to position number 8, if you are doing vaginal delivery, then that is called as occipito-posterior position. And occipito-posterior position is the most common mal position. Right? Breech was the most common mal presentation. Here, presentation is cephalic. The problem is with the position, right? So, occipito-posterior position is the most common mal position, right? Now, if they ask you this question, what is the most common position of the fetus? So, please remember, most common position of the fetus is LOT followed by LOA. Same question if they ask you what is the most common position during labor. Again, your answer remains the same. It is LOT followed by LOA. If they ask you what is the most common occipito-anterior position, just now I told you it is LOA. But if they ask you which is the most common occipito-posterior position, then your answer will be ROP, right occipito-posterior position, right? Now, before we go any further, I want all of you to make 4 circles, right? And in these 4 circles, we are going to mark only that position which is most common. Right? So, in the first circle, you have to mark the position which is most common in vaginal delivery. So, just now I told you the position which is most common in vaginal delivery is LOT. Right? Now, if they ask you which is the most common position in occipito-posterior delivery, in occipito-posterior delivery, the most common position will be ROP, right occipito-posterior position, right? If they ask you what is the most common position in breech, now when you are talking about breech, bachcho, please remember that in breech the denominator is sacrum. Just now we did that, right? So in case of breech, the most common position is left sacro-anterior. Do not say it is LST. There is nothing like LST. Left sacro-anterior, right? Similarly, if they ask you what is the most common position in face, the denominator is mentum. So, in case of face, it is left mento-anterior, right? So, these are the most common positions during some of the deliveries which you have to remember. Clear to all of you? Okay. Now, it's very important for you to understand that how you are going to determine in your image-based questions that which is the position of the fetus. So, I'm going to tell you that. Let me first take a seat and then I'll tell you that. So we are going to talk about how to identify position in image-based questions, right? Now, whenever you get an image and they ask you to identify the position, first thing what you have to do is you have to look where the occiput is facing. Whether the occiput is facing anteriorly or whether it is facing posteriorly. For example, in this image over here, so over here is the occiput. Where is the occiput facing? Occiput is facing anteriorly towards the pubic symphysis. That means we are dealing with occipito-anterior position, right? Now the second thing what you have to look is you have to see whether the occiput is facing in the image towards your left hand side or towards your right hand side. So in this image, it is facing towards what is there in my same will be in yours, right? So it is facing towards my right side, right? So occiput I can see is facing towards my right side, right? So if it is facing towards my right side, now what this image is showing is a picture which has been taken from below, right? Now, whatever is shown, whatever appears to you on your right, when you have to tell the position in the mother, it will be the other way round. If it is towards your right or towards my right, in the mother, it will be left. So, I am going to say it is left occipito-anterior position. That's the only trick which you have to remember. Apart from that, I know none of you are going to make mistakes in identifying whether it is occipito-anterior or occipito-posterior or occipito-transverse. That is something which is visible and you will understand. You are only going to make a mistake in left and right. And because I know you're going to make a mistake in left and right, please don't think about anything else. Just think about what I said just now, that if in the image it is appearing towards your left hand, in the mother, it will be right. And if it is appearing towards your right hand, in the mother, it will be left, right? So, I want you to write this step, how to identify the position. First step is you have to see where the occiput is facing, right? If occiput is facing towards pubic symphysis, that means you are dealing with occipito-anterior positions. If it is towards sacral promontory, that means you are dealing with occipito-posterior positions. If it is midway between pubic symphysis and sacral promontory, that means you are dealing with occipito-transverse positions. That's the first step. Second step is, if in the image, occiput is towards your left hand side, then in the mother it will be right, right, and vice versa. So that's the only thing which you have to remember. Whatever it is showing in the image, it will be opposite towards that in the mother, right? Till here it is clear to all of you? Okay. Now, if you get an image like this, it's very, very easy. And such an image, it came in INI CET 2020 exam. Right? So in INI set exam, they had shown this image and they had asked you, identify the fetal position. Okay? Now, when we have to identify the fetal position, I told you, first thing what you have to do is, first thing you have to see where is the occiput facing. The occiput is facing anteriorly or posteriorly. So in the image, I can see occiput is facing anteriorly. Right? Now, whether it is towards your left hand side or towards your right hand side, it is towards my left side. Now, since occiput is towards my left side, in the mother it will be right. So, I am going to say it is right occipito-anterior position. Is that clear to all of you? That's the only thing which you have to remember. If in the image occiput is towards your left hand, it will be mother's right hand. If it is towards your right hand, it will be mother's left hand. Clear to all of you? Now, till the time you get an image like this, it's very easy. Now, in order to make it a little, difficult, they may give you an image like this. Now, again, when they are giving you an image like this, first thing again is you have to identify where is the occiput facing. And in order to identify where is the occiput facing, I am going to take, help of this fact that posterior fontanelle and anterior fontanelle. So anterior fontanelle is diamond shaped, and posterior fontanelle is triangular shaped, right? So this means over here, this, what I am now marking in red color, this is the posterior fontanelle, right? And I told you it is the posterior fontanelle which lies near the occipital bone. It lies near the occiput. So I have to look at the position of the triangular shaped fontanelle, right? So what you have to do, if you have to identify the occiput, in order to identify the occiput, you have to identify posterior fontanelle, and posterior fontanelle is triangular shaped. Now, wherever the posterior fontanelle is facing, that will be the position. So over here you can see that the posterior fontanelle is facing towards the pubic symphysis, and there is the sacral promontory. So I can see that occiput or the posterior fontanelle, whether I say posterior fontanelle or whether I say occiput, it's one and the same thing because posterior fontanelle lies near the occiput. So I can see that the posterior fontanelle is facing anteriorly. This means I am dealing with occipito-anterior positions, right? Now, second step for direction, again, same like previous. For direction, the rule is same like previous. So over here, because occiput is facing towards my right hand side, right? So in the image, the occiput is towards my right hand side, the posterior fontanelle is towards my right hand side. That means in the mother, it will be left. So this becomes left occipito-anterior position. Is that clear to all of you? Again, I'm telling you, if you get an image like this, first you have to see which fontanelle is the posterior fontanelle. And we know it's the triangular shaped fontanelle which is the posterior fontanelle. We also know this, that the posterior fontanelle is close to the occipital bone, right? So wherever the posterior fontanelle will be facing, in the same way, occiput would also be facing. right? So in the image, I can see posterior fontanelle is facing anteriorly towards the pubic symphysis. So here it means we are dealing with occipito-anterior position. And now the second rule is the same. Now because here occiput is, or the posterior fontanelle is towards my right hand side, so in the mother it will be the opposite, so it will become left occipito-anterior position. Clear to all of you? Let's practice one or two images again, because these are very, very important images. Direct question comes on these images, and if you know the funda, you are going to mark it correctly, right? Okay. So image A, image B. Now in image A, this over here is the posterior fontanelle. Posterior fontanelle is facing where? It is facing towards the sacral promontory. Right? That means it is occipito-posterior position. Right? Now, tell me, it is facing towards your left hand side or towards your right hand side? So, it is towards my left side. In other words, it is towards your left side also. So, in the mother, it will be right. So, that means this is right occipito-posterior position. Right? Okay. Now look at the image B. In image B, what you are seeing? In image B, occiput or the posterior fontanelle or the triangular looking fossa, it is facing anteriorly, right? So this is occipito-anterior position. Now because it is towards my right hand side, so in the mother it will be left. So it is left occipito-anterior position. So this image and this image are the same. Clear to all of you how to identify fetal positions on images? Only funda what you have to remember is don't forget to interchange the direction. Right? If it is towards your left hand side, mother's right. If it is towards your right hand side, mother's left. You have to understand all the concepts, and then you have to apply those concepts clinically as well as in clinical based questions. Don't mug up things. If you understand a topic, that's going to remain with you for a longer time. But if you mug up something, it's not going to remain with you for a long time. So, I really want all of you to understand your concepts in Obs and Gynae so that any type of question which you get in Obs and Gynae, you are able to answer it correctly. Take care, keep practicing your MCQs and keep revising your notes. Bye.